Welcome to the Deep Dive. Today we're tackling something huge, something that's really shifting how we think about patient care and diagnosis. We're diving into hereditary cancer syndromes. This is becoming just absolutely essential knowledge for, well, for you, the radiologist.
Absolutely. It's moving beyond that niche topic area.
Exactly. You know, for years, the focus was on HCSs causing maybe 5 to 10% of cancers. But the real kicker, the thing that changes the game, is realizing how many carriers are out there.
Right. The prevalence of people with these pathogenic variants in the general population is much, much higher than those cancer stats suggest.
We're talking common syndromes like HPOC or Lynch syndrome, maybe 1 in 300 people. That's pretty common.
It really is more common than many genetic diseases we learn a lot about.
So our mission today is to really dig into this, pull out the key insights from the source material, and give you a shortcut to feeling confident about HCS. We're looking at it squarely from your perspective as a radiologist.
Yeah.
Understanding the genetics, sure, but crucially, how imaging fits in for surveillance and what specific findings you need to recognize for the major syndromes. Because your interpretation, that finding you spot, could be the critical first step.
And that's exactly it. You often are the first responder here. Maybe it's a routine scan, an abdomen. You see something, a pattern of polyps that seems a bit unusual.
Or a subtle finding in a young patient's breast imaging.
Precisely. Knowing about HCS means that subtle finding isn't just background noise. It could be the first signal of a major underlying risk, not just for the patient, but their whole family.
Triggering that genetic workup, the cascade screening, it's incredibly impactful.
It really can change lives. So yeah, this knowledge is powerful.
Okay, so let's unpack this. How does this genetic predisposition actually show up on our scans? Let's get into the basics of these syndromes.
Okay, so at their heart, HCSs are genetic conditions. They create this significantly higher predisposition to developing tumors because of inherited pathogenic mutations in the germline DNA.
Affecting potentially multiple organ systems.
Right. And while we used to think they were a smaller slice of the cancer pie, new genetic tech shows us that carriers, at least, are far more common than we previously thought. It's like we're seeing the full picture now.
And the clinical impact is huge, isn't it?
Yeah.
We see cancers developing much earlier than usual.
Yes, early onset is a major flag, and often multiple tumors either showing up together, synchronous, or one after another over time, metachronous. That pattern alone should make you pause.
Definitely. And the evidence is clear. Finding these early, getting the right surveillance in place, it genuinely improves outcomes, improves life expectancy.
Absolutely, which puts a real emphasis on the radiologist. You need that heightened awareness, recognizing clinical clues and imaging features that suggest an HCS might be present.
Prompting that timely genetic referral.
Exactly. Think about the patient's history, those anamnestic clues. Multiple primary tumors, bilateral cancers in paired organs.
Cancer at a surprisingly young age.
Right. Or a strong family history of similar cancers, maybe even certain congenital anomalies. These aren't just footnotes, they're vital clues.
So we know why it matters clinically. Let's look under the hood a bit at the genetics. How does this predisposition actually work at the gene level?
Well, most HCSs are monogenic. That means the risk comes from a mutation in just one specific gene. And these aren't just any genes. They're usually critical players in controlling the cell cycle or repairing DNA damage.
And this leads to that two-hit idea, right? Knudson's hypothesis.
Exactly. Think of it like this. The patient inherits the first hit that germline mutation is in every single cell. That's strike one, present from the start.
Okay.
Then, for a cancer to actually develop, a second hit needs to happen. This is an acquired somatic mutation in a specific cell that knocks out the remaining good copy of that gene.
And that's what triggers the malignant transformation.
Precisely. And that head start, having the first hit already there, explains why cancers tend to happen earlier and why patients might get multiple tumors. You're essentially watching for that second hit.
It's fascinating. But does inheriting the first hit automatically mean cancer is inevitable? Is it always that deterministic?
That's a really important question. No, it's not always deterministic. We have to talk about variable penetrance.
Yeah.
Meaning that even if someone carries the mutation, it doesn't guarantee they'll develop cancer. Early studies sometimes suggested very high penetrance, but more recent, larger studies show it's often more in the range of 40% to maybe 80% lifetime probability of developing a related tumor.
So the risk is significantly elevated, but it's not a certainty.
Exactly. Not every carrier gets cancer.
And that's critical for us radiologists, right?
Right.
Because an imaging finding in a known carrier, even if it looks benign or, borderline.
You have to interpret it differently.
Yes, it needs to be seen through the lens of that higher genetic risk. Your interpretation takes on extra weight.
Precisely. Surveillance becomes a strategy to reduce risk, to catch things early. It's not a magic shield, and managing expectations is part of our role too.
Okay, so given these risks, how do we actually monitor these patients effectively? Let's talk about imaging surveillance. Why is imaging so central here?
Well, the main goal is simple. Find cancer early. We know these patients were at high risk for early, multifocal, maybe recurrent tumors. Early detection demonstrably improves survival.
So imaging shifts from being reactive, finding disease that's already causing symptoms?
To being proactive. It becomes a lifelong surveillance tool, often looking for tiny, subtle changes in people who feel perfectly fine. Pre-symptomatic detection.
That really does require a different skill set, a different mindset.
Yeah.
Interpreting those very subtle findings, understanding how these HCS-related tumors behave differently sometimes.
Absolutely. And it demands teamwork, close collaboration with genetic counselors, with oncologists, to figure out the best imaging strategy, the right timing.
Choosing the right tool for the job, essentially.
Exactly. The strategy has to be tailored very carefully to the specific cancer risks of each syndrome. It's not one size fits all.
Let's run through some key modalities. Whole body MRI, WB-MRI, that comes up a lot, especially for younger patients.
Yes, it's often preferred. The big advantages are pretty clear. No ionizing radiation, which is huge for repeated lifelong screening.
Crucial.
Plus, you get fantastic soft tissue contrast. You can cover a large area efficiently, look at multiple organs at once. It's really ideal for picking up things before they cause symptoms.
So main uses are pediatric surveillance, looking for multifocal disease, screening brain, spine, soft tissues, abdomen, pelvis. Pretty
It's
broad.
very broad. Then you have PTCT. It gives you that functional information alongside the anatomy. FDG for metabolic activity. Dotatate for neuroendocrine tumors, for instance.
Useful, but the downside is radiation.
Exactly. Cumulative radiation dose is a major concern for HCS patients who might need screening for decades. So its use is more targeted.
Like for specific neuroendocrine tumors, or maybe looking for malignant change in nerve sheath tumors, MPNSTs, evaluating how active a lesion is.
Right, those are key applications. Conventional CT, of course, still has a role. It's fast, gives great anatomical detail. It's everywhere.
But again, radiation.
Mm-hmm.
And less soft tissue detail than MRI.
Correct. So it tends to be used for specific things, maybe targeted pancreatic imaging or checking the colon after a positive stool test.
What about ultrasound?
Ultrasound is great. No radiation, real-time, widely available, inexpensive.
But very operator-dependent, limited field of view.
Yeah, those are the limitations.
Yep.
And gas can be an issue. But it's used a lot for specific organ surveillance, like annual abdominal scans in VHL syndrome, or looking at the thyroid or adrenals in Menin syndromes.
And mammography. Standard for breast screening, but maybe less ideal here.
Well, it uses radiation, can be less sensitive in dense breasts, especially in the younger women often screened in HCS. So MRI often supplements or even replaces it because of the age factor and the better contrast without the radiation.
Got it. And we should mention optical colonoscopy too, though it's not strictly imaging in our sense.
Right, but it's the go-to for high-risk colorectal screening, like in Lynch or FAP, direct visualization, biopsy capability. That's key for finding dysplasia or early cancer, but it is invasive.
Now, you've mentioned radiation multiple times. Let's really emphasize minimizing that dose, especially in kids and adolescents facing years of scans.
It's paramount. Remember the two-hit idea. These patients already have strike 1. We absolutely do not want imaging radiation to provide strike 2.
That second somatic hit.
Exactly. And some syndromes are known to be extra sensitive to radiation, like ataxia telangiectasia, or Liefeld-Mini syndrome, where there's a known higher risk of radiation-induced cancers.
So the LRRA principle, as low as reasonably achievable, is not just a suggestion here, it's critical.
Absolutely critical. As radiologists, we have to champion the non-ionizing options, MRI and ultrasound, whenever possible. And if CT or PTCT is necessary, we need to rigorously justify it and optimize that dose meticulously. We're gatekeepers for their safety.
Okay, this is where it gets really practical for the listeners. Let's dive into some major syndromes and what you need to look for on the images, starting with HBOC hereditary breast and ovarian cancer.
Right. Primarily driven by mutations in BRCA1 or BRCA2.
And the cancer risks are significant breast cancer, obviously, female and male.
Yes, don't forget male breast cancer risk. Also, ovarian, prostate, pancreatic cancer, and even melanoma risk is elevated. So surveillance needs to cover these areas.
For the breast, you mentioned MRI being particularly valuable.
Extremely valuable. Younger age at screening, need for long-term follow-up, dense breasts sometimes. MRI's superior contrast without radiation makes it often the preferred tool over mammography in this group.
And for ovarian or pelvic screening?
Regular pelvic imaging, usually transvaginal ultrasound, sometimes pelvic MRI, looking for early ovarian changes. For the pancreas, especially with BRCA2, surveillance might involve MRI or specific pancreatic CT protocols. Melanoma is mostly clinical skin checks.
Okay, next, Lynch syndrome, also known as HNPCC, mutations in mismatch repair genes like MLH1, MSH2.
MSH6, PMS2, or EPC, yeah. Big risk for colorectal cancer, often early, often right-sided, often multiple tumors over time. And crucially, it's the most common hereditary cause of endometrial cancer.
The only known heritable cause, actually.
That's right. Plus, increased risks in biliary tract, brain, ovary, pancreas, stomach, urinary tract. Sometimes small bowel or prostate, too. It's quite a spectrum.
And you can see specific variants, like Muratori with the skin tumors, or Turco with brain tumors, plus colon polyps. Patterns to recognize.
Definitely patterns to keep in mind. Imaging-wise, for colorectal cancer, you might see those early right-sided lesions. Colonoscopy is the main screening tool, but CT colonography can be an option.
And our indirect role.
Crucial. Recognizing potential Lynch cases can prompt universal testing of colorectal tumors for microsatellite instability, or MSI. That testing is key to diagnosing Lynch and identifying family members at risk.
Right. And for the other risks, endometrial, ovarian.
Regular pelvic imaging ultrasound, MRI, for the urinary tract, imaging the bladder, kidneys, renal pelvis, and maybe brain MRI if Turcotte syndrome is suspected.
Let's move to FAP, familial adenomatous polyposis, APC gene mutation. Hallmark is those hundreds, thousands of colon polyps.
Huge colorectal cancer risk there. But the really fascinating part for radiologists, and where you can make a huge difference, often involves the benign findings.
Ah, right. These can be the first clue.
Exactly. You might be the first person to spot characteristic osteomas, those benign bone growths, especially in the jaw or skull, sometimes long bones, or maybe soft tissue desmoid tumors, which happen in maybe 10–15% of FAP patients and can be locally quite aggressive.
Gastric fundic gland polyps, too. Seeing these, even if they seem unrelated or incidental,
Should immediately make you think FAP and trigger a referral for genetic assessment. They're not just incidental findings, they are major diagnostic clues, sometimes appearing before the polyps are even discovered.
so endoscopy is key for the polyps. But imaging like CT or MRI helps assess the extent, looks for those extracolonic polyps, checks for cancer, CT or MRI for the osteomas. MRI is generally preferred for evaluating desmoids.
And brain MRI if there's a suspicion of Turcotte syndrome variant associated with FAP, looking for medulloblastoma.
Okay, how about Liefeld syndrome, LFS? Rare but
Sure.
devastating. TP53 gene mutation.
Highly penetrant. It's essentially a pan-cancer syndrome. Cancers can appear incredibly young. Half of carriers might develop cancer by age 30.
And the range of cancers is just staggering. Soft tissue sarcomas, osteosarcoma, rhabdomyosarcoma.
Breast cancer, leukemia, lung cancer, lots of different brain tumors, gliomas, choroid plexus carcinomas.
Adrenal cortical carcinoma too. And we absolutely have to remember that heightened risk of radiation-induced cancers.
Makes surveillance incredibly challenging, but also incredibly important. And because the risks are so diverse and start so young, whole-body MRI really becomes the cornerstone.
The indispensable tool, especially in kids, avoids radiation, covers everything.
Pretty much. Detailed brain MRI is also essential for CNS surveillance. Regular MRI helps watch for sarcomas. PCT might have a role for specific things, like checking MPNST activity or guiding biopsy, and dedicated adrenal imaging.
It's a demanding syndrome to manage, for sure. Lastly, PTE and hamartoma tumor syndrome, or Cowden syndrome. PTEN gene.
Right. Increased risk of benign and malignant tumors, especially breast, uterus, thyroid.
And again, like FAP, the characteristic finding is often benign the hamartomas.
Exactly. Multiple hamartoma, skin, mucous membranes, GI tract, even brain. These are the key early clues. Seeing these should make you think Cowden.
Just like with the osteomas in FAP. Recognizing these specific benign patterns is crucial for triggering that genetic workup.
Absolutely. So for surveillance, regular breast imaging, often MRI, routine thyroid ultrasound looking for nodules, pelvic imaging for the uterus, maybe GI imaging for hamartomas, though endoscopy is often used. and brain imaging if needed.
So pulling it all together, HCS represents a really dynamic and critical field for us. The increased awareness of carriers, the better understanding of penetrance, it just highlights how important it is for radiologists to be tuned in.
You really are often those first responders. Spotting those characteristic findings, malignant, or sometimes those specific benign ones like osteomas or hamartomas, can be the crucial first step.
Yeah, it requires understanding the genetics, that two-hip model, the variability, and how that shapes the surveillance plan for each patient, using all our imaging tools thoughtfully.
And carefully choosing modalities based on age, specific risks, and always thinking about minimizing radiation. WBMRI is a game changer, especially for younger patients, but PTCT, ultrasound, CT, they all have their specific important roles.
Integrating imaging with a molecular side, like MSI testing for Lynch, that seems key.
It's the hallmark of modern HCS management, absolutely. Multidisciplinary teamwork.
So for you listening, what's the takeaway? It's that your expertise, your vigilance goes way beyond just diagnosing disease here. It's about changing patient lives, changing family histories, sometimes across generations.
You're deciphering potential genetic risks on scans and guiding preventative strategies.
Right. You're not just reading images, you're potentially altering trajectories. So here's a final thought to leave you with. How might things like AI-driven image analysis or even more advanced genetic testing change your role in HCS down the line? Could we get even better at finding these risks before they ever cause harm?
Food for thought. The field is definitely evolving fast.
Absolutely. Thank you for joining us on this deep dive. We'll catch you next time.